So I had to change my settings yesterday for something, and I just remembered I need to change them back. Ah, there you all are. I had it on hide non-video participants. So I was like, I can't be the only one on the Zoom now. I wasn't. All right, I would give it a minute for other people to sign on. All righty. Hope everybody is doing well today. I will do the same reminder I've been doing for all my classes. Make a plan for voting. You can vote early through Saturday, and then you can vote in person on Tuesday, a week from yesterday. It's very important to vote, exercise your civic duty. So please, please, please vote, vote, vote. It's very important. People literally died to give you this opportunity, both soldiers and also protesters, for people of color and for women. So make sure that you exercise that right. All right, I'm opening up our PowerPoint because I forgot until a minute ago that I have a couple more slides to go through for y'all. Yes, so true. Hardest part is leaving the house. If you live in Virginia Beach, you can go down to the Virginia Beach voter register and vote early there. If you got an absentee ballot, you can go drop it off there in person. Hooray, going today. But yeah, make a plan to vote. I know that Brian Karinsky in the, not the community service office, it has a really long name, is helping people to get there. So if you need a ride, I think they're gonna have vans on election day. So make sure that you pay attention to the emails. Wesleyan Engaged, there we go. So I'm having the same problem I usually have, which is I can't click and talk at the same time. So give me a second here.
I just posted in the chat, there's a link for the Virginia Beach voter site, and it tells you like where you can go, and it also tells you the wait times at all of the voting, like early voting locations.
That's awesome. Thank you. That's great. So I also just realized as I'm reopening the PowerPoint for today, that I was gonna make an image PowerPoint while y'all do the group activity, but I actually already made an image PowerPoint basically because all the images for our authors, except for Linehan, are in the regular PowerPoint. So I'll find a picture of Linehan while you all are doing the group work after we go through this. Alrighty, I'm going to share screen here. Okay. So only a little bit more to go through, and probably my favorite piece of all this. So I'm going to talk about Aaron Beck. He is sort of one of my, not even sort of, he is one of my psychology heroes. I was trained in grad school in his type of therapy, which is called cognitive behavioral therapy. And I've gotten to see him speak several times at conferences. He's in his 90s, and the last time I saw him about 3 years ago, he was still going, still doing research at like 94, I think. So I don't think he knows the meaning of the word retire. And he really, along with Ellis, revolutionized how we do therapy. And it's really interesting because as we go through this, you'll see that Beck's therapy is really similar to Ellis's, but it's much more popular. And one of the main reasons for that is that Beck, as I mentioned, to this day, is still pumping out research. He was all about doing research to make sure this works. And when you're training in graduate school, you're going to be doing it based off the research that exists, right? So while Ellis wrote popular things that went to the general population, Beck really did sort of cater to the people who were coming up in training. And in fact, he still does, and I'll kind of explain that as we go through. So he's still alive. Was born in 1921. He was called Tim Beck by those close to him. My psychotherapy professor when I was in grad school had met him and interacted with him, and so called him Tim Beck, but like didn't like give us a reference for that. So like in my notes for a while, I just like thought it was a last name, like Timbec, all one word. Typically, you know, formally you see him as Aaron Beck. So he started as a psychoanalyst, as most therapists and theorists did at that point. And he decided he wanted to see if his theories worked, if they made sense. He actually had theories about the dreams of people who were depressed, and he thought he could sort of prove psychoanalysis by researching them, and found that that wasn't actually the case, but that he sort of came up with cognitive theory and cognitive therapy out of that research. The American Psychoanalytic Institute rejected Beck's membership application on the grounds that his mere desire to conduct scientific studies signaled that he'd been improperly analyzed. And apparently, the decision made him angry for years. So just like RET becoming REBT, CT, cognitive therapy, has become CBT. Interestingly, Beck himself still refers to it as CT, even though there are the behavioral components. But largely, most people refer to it as cognitive behavioral therapy. And in fact, the conference that I traditionally go to, that I'm going to virtually this November, is the Association for Behavioral and Cognitive Therapies. He really wanted to look at cognitions and how they contributed to psychopathology. He thought that cognitions caused one to become depressed and kept people depressed. Again, he started with depression, but moved beyond that. His most recent research looked at using these techniques for people with schizophrenia. And he developed his theory independently from Ellis, but about the same time. And then as he started reading Ellis, he was certainly influenced by him. And you kind of saw that in the reading you did for today. And the reading you did for today is actually by Beck's daughter, Judy Beck. So I have also gotten to see her speak. She is another of my psychotherapy heroes. So she was born in 1954, and she founded the Beck Institute in Philadelphia. And the Beck Institute is a training center. So they train therapists to do cognitive therapy. And they traditionally do it in person, but they're doing it all over webinars right now. This book here, Cognitive Therapy Basics and Beyond, was sort of my guidebook, Bible, what have you, when I was first learning how to do therapy. It's very clear. It really helps you to do cognitive therapy well. And then also, as I was working with the individuals who are undergoing bariatric surgery, I really liked her Beck Diet Solution, which isn't actually a diet. It's about using cognitive techniques to help you maintain a healthy lifestyle. And I did a workshop with her on this at ABCT one year. And she explained she didn't want to call it this, but her publisher was like, it'll sell better if we do. So the Beck Diet Solution, it became. So cognitive therapy and cognitive theory, like I mentioned, was developed for depression, but now has been applied widely to almost every psychological disorder. So cognitive distortions are the idea that people with psychopathology see or think of things differently. They interpret it differently, essentially. Schemas are the main thing here. They're also called core beliefs. Beck thought that people had illogical ways of processing information, And psychopathology was a logical outcome of those illogical thoughts. So again, very similar to Ellis's idea about irrational thoughts, right? And they're called core beliefs also because they get to the core of your issues. He talked about negative automatic thoughts. Then these just pop into your head. You can't control them. These are the voices in your head where you tell yourself like, oh, I'm an awful person. This is horrible. Nothing's ever going to get better, right? So looking at depression, he came up with the negative cognitive triad, which is looking at the negative view of the future, of yourself, and of the world around you. So there are behavioral components, and there always have been. So Beck's initial therapy for depression, the first portion of it, a few weeks, is all behavioral. It borrowed heavily from behavioral treatments of depression. And he talked a lot about thought experiments. So if someone says they are unlovable, you think about others that might actually love them, or you have them think about situations where they have been shown love. Or if they say they can only be happy in a relationship, ask them to think about a time they were happy, right? And it might be a time when they were not in a relationship. So it gets at the same ideas as disputation, the D in REBT. Behavioral activation is especially important for people who are depressed. A lot of times they won't go out of the house or do anything. I had a very depressed client I saw while I was on residency that she would only shower once a week because it just felt too daunting to her to do otherwise. Luckily it was like before she saw me. So I didn't have any sort of smell issues. It was essentially she left the house only to see me. So Beck found that just by getting them out and doing things, depressed patients felt better. And this goes back to Adler's idea of acting as if, right? You tell people to fake it till they make it, or act as if they're not depressed or as if they're not anxious. The object is to get them trying it and overcoming cognitions that are getting in the way of progress. So you can present it to the clients as experiments, like, let's try this and let's see what happens. And sometimes they will be all in and sometimes they won't. Like I had a client once that I had, I gave her an assignment and she came back the next week and she said, I thought this was stupid, but I did it anyway. And it benefited her. So I was like, see, you can trust me, I swear. But that's a big part of any type of therapy is building up trust with that person. So this is certainly something that you need to infuse into this. Beck used a lot of humor, just like Ellis did. The therapeutic relationship is still very important. And then identifying and challenging these automatic thoughts. So Beck used very similar techniques to Ellis here. So I'm pulling up, and if you want to pull up the handouts here, I'm going to have to rotate it around real quick. And then I'll screen share. Okay. So here you can see that it is pretty similar to Ellis's ABC sheet. It's just sort of expanded outward. So we still have our antecedent, our situation. We still have our B, our beliefs, our automatic thoughts. Here, the only C consequences they were looking at were emotions. And then you come up with your rational response, you do your disputation. And then like Ellis's, you sort of look back and say, like, did that actually help me? And when you first start doing this with clients, it doesn't. But by the time they've been doing it for several weeks, it is practice, right? They will actually, you'll see substantial decreases in both the belief in the automatic thought and the emotions, the negative emotions they experience. And here, down here at the bottom of this handout, you can see some of the questions that you can use to do the disputation to help them find the rational responses. So what's the evidence for this? What's the evidence against it? Is there another explanation? What's the worst that could happen? Could you survive it? What's the best that could happen? And then what's the most realistic outcome? And what should I do about it? My favorite is probably 6, where you think, if my friend was in this situation and had this thought, what would I tell them? Because in general, we're kinder to our friends than we are to ourselves, right? Particularly if we experience psychopathology. So that is something that is, very well used, I would say, within his, in this therapy. The other thing I realized now that I have this handout open that I promised I'd go back to explain a little more was this chart about Ellis's therapy and theory. So we've got our A's, our antecedents, those situations, right? And that can lead to irrational beliefs or rational beliefs. If you have rational beliefs, you're going to have good, constructive behavior, coping thoughts, appropriate feelings. If you have irrational beliefs, you're going to be having self-defeating thoughts, feelings, and behaviors. And, if you have sort of underlying things that make you feel hopeless, helpless, make you feel like your goals can't be accomplished, that's going to lead into it. So Ellis's idea was, if you do this therapy, and again, very similar to Beck's therapy that we're talking about, then that's going to help you get from those irrational beliefs back up to those rational beliefs. So again, it's all about, both of these techniques are all about what are you telling yourself and how is that negatively affecting you? So as you work through cognitive therapy, you build up to identifying and challenging core beliefs. So once you get people to recognize their automatic thoughts, you help them sort of drill down to get to their core beliefs or their schemata. So Aaron Beck labeled these schemata, or I've heard them called schemas. We like to use different languages even within the same technique. So these are examples in depression in particular, and the idea is to change these into more adaptive ways of thinking. And I'm not going to switch back to the handout, but there are some examples of these on the handout as well. So non-dimensional and global are, I am fearful, right? It's like a blanket statement. I'm going to be fearful no matter what. There are absolutistic and moralistic ones. I am a despicable coward. There are invariants. I will always be and always have been a coward. Character diagnosis, people are really good at this. There's something wrong with me. I'm just broken in some way. I have a defect in my character. And then irreversibility, believing there's nothing you can do about it. Judy Beck reframes these as core beliefs, and for her, they tend to fall into 2 main categories: thoughts about feeling helpless and thoughts about feeling unlovable. People can have core beliefs from both areas, and the idea is really to get down to one or a very few of these that are most relevant for the person and begin to challenge them. And again, what's the evidence for them? What's the evidence against them? So I am unlovable is unfortunately a really common one for therapy patients, or I am bound to be alone. And that can drive any manner of psychopathology, right? So if you think I'm bound to be alone and the only way to get there is to, be more attractive, right? You also have the I am unattractive. That could lead to an eating disorder, right? If you think you are a failure, that's going to be self-defeating. So here really is the cognitive model of looking at these things. Again, it's pretty similar to Ellis's model. So you've got your situation, and then that's linked to your automatic thoughts. Those are going to influence your emotions, your behaviors, also your physiological responses. So for example, when you have a panic attack, right? You have physiological symptoms, you have shortness of breath, your heart racing, things along those lines. And the idea is that the automatic thoughts don't come out of nowhere. The automatic thoughts are driven by these core beliefs. And then this model is how we present this to clients. It's like reciprocal determinism. We talk about how these things kind of go back and forth. So, you have your event, and it's not that you go immediately to the emotion, right? It's your thoughts about it, your cognitive appraisal, your thoughts, your beliefs. Those are going to feed into the emotion. Emotions will feed back into those thoughts. Emotions will feed into behavior. Behavior will feed back into your thoughts, right? Like if you try to do something and you don't do well, I shouldn't have even bothered, right? And then, like we talked about with reciprocal determinism, the behavior is going to affect the environment as well, right? Because other people are going to react to you. So a big thing about doing cognitive therapy, and again, your article today mentioned, is that these are empirically supported treatments. All cognitive therapies are based on research. Does it work? Does it work better than other things? And so they're actually tested, and then they're written up into formal manuals that are essentially how-to guides for skilled therapists. And manualized therapies are where you want to be very precise and do the therapy truly in the way it's intended. And you definitely use these in research. You certainly use them when you're in training. You might sort of adapt these. And I like, again, that you're reading for today talked about this. So that, like, yeah, they're manuals, but you would adapt it to the individual person, right? But for example, the VA, when I was there 10 years ago, had just started doing their rollout of manualized therapies for depression and PTSD. So they were really encouraging all of their therapists to do that. And even therapists who have been treating patients for years and years go to training, get supervision, and submit tapes to make sure they were doing it correctly when the VA switched over. If you're trained in CBT, you can honestly pick up the manual for a disorder you're not as familiar with and do it, and do the therapy with the person because it's very clear and there are session-by-session breakdowns. Most times CBT will start with what we call psychoeducation, where clients are taught about the nature of their disorders. We talk about, what happens with trauma when you try to ignore it. In cognitive processing therapy, we talk about how purging doesn't work when we talk to people in bulimia, in cognitive behavioral therapy for bulimia. In panic disorder, we talk about what's going on in your body, which is just the fight or flight reflex overreacting. And so that can be really helpful and almost like magical for patients to just understand what's happening. There are homework assignments. They can include those thought records, but they can also include those acting as if, go out and do something. Hypothesis testing. So everything is presented to the client as a hypothesis to be assessed, even within the therapy. And the therapist and the client are going to work together. They're a team. I would tell clients, you're the expert on you, I'm the expert on this type of therapy. And so we would work together to solve their problems. And so here is a list, and this is certainly not comprehensive, but of the types of disorders that are treated by CBT. All righty. Scooch this out of the way, readjust down my camera so you can see more than the top of my head. And I'll grab the link for today's group assignment and put it in the chat. I did make sure already that it's shareable. I'm learning slowly but surely, y'all. Okay, so while I'm setting up the breakout rooms, go ahead and get that link going for yourself. Alrighty, since there's 5 questions, I'm going to do 5 breakout rooms. And just double check my options here. Yep, we're good to go there. And I am going to open all the rooms. So I will see you all in about 20 minutes, and then we'll have a very brief discussion about your assignments. Alrighty, welcome back, everybody.
I think this is the first or second time the group I've been in finishes all the questions before the time's up. Like
Nice.
that never happens.
Next time, maybe I could give you 25 minutes. This time I was trying to squeeze it in because we don't have much time left. But I did want to show you a picture of Marshall Linehan. She developed DBT. This is obviously a very early reading you did by her. But she has gone on to test this almost as widely as CBT, basically, and it works really well. And it's been adapted for other disorders. You can do DBT for eating disorders now, and they address the eating disorder behaviors, like they address the parasuicidal behaviors in main DBT. So, alrighty. So we only have about 4 minutes left. So rather than go through question by question, I'll just ask what stood out for you all from these readings.
I would say like for the like CBT, what stood out to me is like how like they talked about how they like constantly change and alter like their plan and how they make it like kind of like specific to that patient, because I feel like that, you know, like probably makes it like work better instead of trying to like give them a therapy that's generalized for someone with their like disorder or condition.
Yeah, and that's really important that you adapt it. I'll give you an example. When I was doing CBT with a client with, she had bulimia, but she also had type 1 diabetes, and her purging mechanism was she wouldn't take her insulin, which means your body doesn't process the food, basically. And it's obviously super dangerous. She ended up in the ER more than any of my other clients. And she just refused to engage in normal CBT. She didn't like the idea of homework. She didn't like anything about it. And so I just reframed and used different language for her, and we did things that worked together. And, you know, it worked. It was the first time she'd ever gotten an A1C rating that was readable. It was always like above the range. And she had been about to lose her doctor for non-compliance. So she was able to keep with that doctor, which was great. All right, we've got about a minute or so left. Anything else stand out for people?
I just thought it was really interesting with is it Linehan? Linehan's theory. I didn't I had never, you know, heard of a therapy that worked with suicidal people or people who are going through suicidal thoughts. And I think it's really interesting, you know, about her whole like therapy. And she said it was like she was really determined to find a therapy that would help suicidal people and who were deemed beyond being saved. And it felt like, and then also I also looked on this website, and it says, I felt the pain that my clients feel as they wrestle the emotional demons that tear at their souls. Like that's a hard job right there. Like, and it's kind of hard to say, like, I guess it'd be challenging to find like maybe the right words to say to certain clients. You know what I mean?
Yeah. And I'm going to throw in the chat real quick so you all can read it on your own time. An article the New York Times did about Linehan about 9 years ago now. So the reason she cares so much is because she had this, and she had this in the 70s when there was no treatment, and they would just lock her in a padded cell in an inpatient unit after she self-harmed. So it was incredibly important for her to make this type of therapy. So she took behavioral cognitive principles, and then she incorporated the mindfulness component that a lot of the newer cognitive therapies incorporate as well. Yeah, I think that's really true. And I've done DBT, and it's hard. It's actually, to be honest, one of the main reasons I'm not a therapist right now, because I would wake up like worried about
for the last question, we were talking about how like organized, in depth, and involved and goal oriented it was, which made it sound, you know, really, really good, but how difficult it would be because it requires so much commitment by the therapist.
By the client, which is really hard when these clients don't usually commit to things, right? Yeah, you really got it spot on. Yeah, it actually has four modalities now, which is the two main ones she mentioned, the group and individual, the phone coaching, so they can call you and when they're going to self-harm, and you say, okay, what can you do? What skills can you do instead? If they call you and they've already self-harmed, they're like, sorry, I can't help you. So you don't reinforce the self-harm. But the fourth modality, really important, you as a therapist need to have a group of other therapists who are doing DBT that you can like essentially have a support group with because it's so hard for the therapist. Alrighty, well, I know we didn't get to talk about it too much, but hopefully in your groups you had good conversations. Make sure one person from each group shares the document with me, and I'll do my typical sticking around if anybody has any questions. If not, I will see you all on Friday.
Bye. Thank you.
Have a good weekend. Thank you.